Let's just look at morphine. All right. So what is great about morphine is we use it for a lot of things because number one is morphine. We'll just write this up here that it will cause vasodilation. It's not a may, it will. So it's going to lower blood pressure. Now, that's absolutely going to happen. Now, the good part of that is morphine does tend to dilate cardiac vessels more so than regular vessels. So that's why you'll see morphine in the chest pain protocol. But it will cause vasodilation, which it will lower blood pressure. All right. The other thing here, which is not really spelled out in this protocol, but when you look at how to administer this drug, it is a slow IV push, which means 2 minutes is what that means. It is a 2-minute administration. It is a very slow push. Why such a slow push? Because it causes a massive histamine release when you give it. That's exactly why they start itching. Okay? So the faster you give it, the faster the histamine releases, and they do. They get the crawlies and the itchies and this right here. So slow administration will ease that in there. The other thing that a rapid push will cause is vomiting. It will cause vomiting. Like you can take morphine and go, they're going to puke. So the slower you give it, the less likely they are to actually react that way. So when we look at 2 to 4 milligrams IV, and if you draw that up, it's not that much. It's a little bitty amount that is in your syringe. So what I like to do is take that and you'll draw it up. I like to use maybe a 3 or a 5 cc syringe, sometimes a 10, just whatever you got, because you got to draw it up in a little syringe to figure out how much you got. But you know, draw it up in a syringe and then hook that to the IV line and then pull back and fill that syringe full of saline. And then you can mix it up. And then that makes, if I've got 10 cc's to administer, 2 minutes is a lot more manageable now. And just start easing it. And if I feel like I'm getting ahead, well, I'll just stop, pinch the line off, draw up more saline, and then just keep going. And what you're doing is diluting that medicine down, but now you're able to give that over the 2-minute time frame. All right, and that reduces some of this right here. Now, vasodilation is still going to happen, but it will reduce the histamine and vomiting potential. Okay? Now, fentanyl. Oh, wait, here's the other thing I didn't put about morphine. Morphine will cause a decrease in their mental status. It will. Nobody takes morphine and is still like functioning like normal. It does alter the mental state. So that is another thing to think about with morphine. And because of the decreased mental state, you also get decreased respiratory. So I'll just write respiratory up here as well. That's going to happen. Okay, so let's talk about fentanyl. Talk about fentanyl. Let's change to a different color or something. Let's do fentanyl in green. Why not? Okay, so fentanyl. What's really neat about fentanyl is it does not affect the blood pressure. Now, there is always the weird patient that responds, but typically it does not cause vasodilation. So, yeah, that's why it's so good for that, is because it doesn't cause the drop in blood pressure, okay? The other cool thing about it is it does not have a histamine release. It doesn't do that, all right? But it is still a slow push. It is still a slow push. Why? Rapid push will cause vomiting. So we'll just put that. We'll have nausea and vomiting. It's going to happen. But here's the other weird phenomenon with rapid push of fentanyl is something called locked chest. So if you rapid push fentanyl, it can cause rigid chest syndrome, which literally locks the chest for a couple of seconds. But those couple of seconds could be long enough to cause respiratory problems. Okay, so we kind of want to be mindful of that right there. So it is still a great idea to do a slow IV push about it. Now, both of these medicines have a delay in taking effect. Both of these do. So what that means is when I administer it, don't expect immediate results. It takes a while for it to go through the system and to be able to work. Okay, so what happens, a lot of these medicines convert to something else, and that's actually how it works. So it has to take time to break that down and convert over. And so that's where we start looking at, being very mindful of that. So what that means is when I give these medicines, notice the dosing is 5 minutes. So when you give it to them, the clock doesn't start when I start giving it. The clock starts when I stop giving it, and we have flushed it into the patient. Now the clock starts because it can take up to 5 minutes for it to take effect. I have had patients that it didn't take effect in 5 minutes, and you go ahead and give them the next dose, and then the two doses basically stack on top of each other, and then it takes effect. So you just kind of, be aware of that we want to spread these out. But if it is taking effect and holding, then what that means is in 5 minutes, it could also start to wear off. And so you may have to redose and redose, all right? And notice that here we hit, every Q5 is needed. And then here we get a range, 25 to 50 mics. May repeat 5 minutes as needed, but you don't want to go over 100 micrograms because of the stacking effect. All right? So you may have to call. It doesn't mean you won't give more, but what it means is if I hit the max, then we may have to call and, be able to give some more as we go through that. All right? So let's check this out. Oop, that was cool. Let's go up here to the Toradol and the ketamine, all right? And let's talk about those two, all right? So the Toradol and ketamine. Toradol, now if we notice the two we just talked about was paramedic and critical care only. This guy we see down to the advanced EMT level. And Toradol is excellent on muscular pain. It's excellent on muscular pain. So we'll put this up here, that it is good for muscular pain. And this is where we'll see a lot of trauma. It's decent in, but the biggest things is like, you want to make somebody happy that's got kidney stones, Toradol is the answer. Back strain, Toradol is the answer. It's great on muscular type pain. The problem with it though is, like we said, is this one can actually cause some bleeding disorders. So that is concerning in my trauma patients, that it could lower the clot threshold. So that's one thing I'm kind of concerned about. I'm not going to say I wouldn't do it, but I would definitely think about it. And I'd be aware of that as well. Okay. Outside of that, we talked about, kidney issues and stuff like that. We do want to avoid that. So then Alabama comes in and says, okay, that's your primary 3 right there, or 4 actually. We've gone 4. So all levels in EMS have access to pain meds. So we got Tylenol, all levels. Then we go up to the advanced, we add Toradol. And then we go up to the advanced and intermediate, we add Toradol. And then we go up to the paramedic level, we add morphine and fentanyl, but we can also add ketamine at the paramedic level. And Alabama says, try these first, then if those don't work, that's what refractory, ain't working, now we can come over here to ketamine, okay? Now, I'm a big ketamine fan myself, so I'm trying not to be too partial, because what I like about ketamine is it is highly effective at pain control. Highly effective at pain control. The other thing that I like about ketamine is it also tends to raise blood pressure. It does do that. It's a side effect, but it does tend to raise blood pressure. The problem with ketamine is it is guaranteed to lower their mental status. Guaranteed. It is also guaranteed to lower respiratory drive. So the higher the dosing, the more we see these two affected. And that is why if you administer any pain med, honestly, any pain med, let's just get in the habit, instead of breaking out which ones would be better, let's just get in the habit that if we give you pain medicine, we need to monitor respiratory drive. And the best way to monitor respiratory drive is end-tidal CO2, right? And so I'm in the habit of myself, if you say, oh, we're going to give them pain meds, break out the end-tidal CO2. And that way we can just monitor for respiratory depression. Because when this sets in, we may need to actually ventilate our patient, all right? So that may actually have to happen. All right, now ketamine we said is dosed on the ideal body weight. So I see 0.2 milligrams per kilo, but that's not their natural weight. That's the ideal body weight, okay? And so we do that based on your height, okay? There's also, and I should have pulled this up, so let's do that. Let's see if I can find it quickly enough. It's back here somewhere. Whoa, that went really fast. There's the medicine formulary. Make this smaller. That'd make life a whole lot better. And let's find it. I thought I passed it. Whoa, whoa. It would help if I did my homework and did this first. There we are. There it is. There it is. There it is. I knew it's back here somewhere. It's going to be a little crooked, so just bear with me. All right. So this is the ideal body weight chart. So this is the chart. And so we would what we would do is look at their height, and then you can estimate how much their body weight actually would be, okay? And so we see this predicted body weight section here for male, and then over here is predicted body weight for female, all right? Kind of a ditch method, which is the method I use a lot. The ditch method of doing this is we look at the fact of we start at a 5-foot person. And a 5-foot person is 60 inches, which would be 50 kilos for a male, okay? And we come over here, 5-foot person, 60 inches is basically 45 and a half-ish kilos for a female, all right? And then for every 1 inch that you add is basically, if you look here in a male, is for every 1 inch adds 2.3 kilos in the male. And we come over here to the female, and for every 1 inch again is 2.3 kilos. So that's kind of the ditch method of doing it, is we'll look at the patient, how tall are they? 5 foot is, right there at the 60 inch, and that's going to be 50 kilos ideal. And then how many inches above that, we start adding 2.3 per inch. And that's how we calculate it up. And you're like, well, I ain't got no way to measure a patient. But you do. Stretcher is how long? 6 foot. The backboard is 6 foot. All of your full body equipment is based on 6 foot. So if you'll stretch the patient out on your stretcher, you have a 6 foot stick. Now adjust from there. And that's exactly what we'll do, is look at it and kind of, adjust back down from that level. So you can download those charts. They're actually available online, everywhere else, that you can pull those down and have those. And of course, again, you can look at it right there in the protocol manual. Whoop, went too far. Lost myself again. All right, where am I at? I'm at shock. Get out of my way. Shock, and where was I? Oop, right there. Almost. There we go. All right. So this is where we were, okay? And so we're talking again about the ketamine, all right? And we said how to dose it on that ideal body weight chart is very important. We said giving the ketamine will cause respiratory depression, and it will also lower the mental status. So we got to be mindful of those two, okay? So, yeah, online question asked about, is it in the protocol app? It should be in there. It should be in there. So we look at those two that we deal with. Now, the other problems with ketamine is we do see an increase in nausea and vomiting sometimes. See an increase in nausea and vomiting. So a lot of times with ketamine, we'll just co-administer some Zofran on Dancitron or something like that. All right, so this is kind of where we look at. Now notice that we have a maximum slow IV push. There's that 2-minute thing come in there to a max of 25 milligrams. And then we also see the 0.5, which would be more like a repeated dose. That's for IM usage, where we'll go up to 50. Now this is every 10 minutes. So ketamine does take a little while for it to kick in. So what you don't want to do is give ketamine, wait like 3 or 4 minutes and say it's not working and hit them again. That's where they'll stack on top of each other, and then you got problems. So this one takes a little bit for it to bind, but when it does, it does. Yeah, take a lot of patients that are snoring when they get to the hospital. They are nice and out of it, right? You do hear a big red box caution about what's called emergence phenomenon, but in the dosing range that we're using for pain control, you're not going to hit that. Okay, now when I'm using ketamine as a sedative, and I use ketamine as a sedative in my world, and you do worry about emergence phenomenon. What that is when they come out of that, they can hallucinate vividly, right? And there's a whole process, like in conscious sedation, we'll use a process to orient them prior to giving it. But the simple way to avoid emergence phenomenon is twofold. Number one, don't exceed this threshold. That's number one. Number two is if you are using it for sedation, don't let them wake up. And then you don't have to worry about emergence phenomenon. If you are going to have to walk through that, oxygen, very important to hyperoxygenate the patient, and verbal constant reorientation and communication, not yelling and screaming at them. When we do it for conscious sedation, we have them look around the room and look at all the things that we know are real, and then we'll have them pick out an object or a person. And we'll say, now you remember that person is real, and remember what they look like, So when they do start emerging and hallucinating, we can reorient them to that. And a lot of times it's literally follow my voice, focus on my voice, don't look at what's in the room, focus on my voice. And eventually those things will melt away and they'll kind of reorient and come back. So anyway. Yeah, pretty much. Yeah. And it's technically is a horse tranquilizer, by the way, that says not for human use. And look at what we do with it. Yeah. All right. So pain control questions. Anything. All right then. All right. So let's take that away. And let's put this other presentation